Hi, welcome to the session, Telehealth Policy and Genetics Care Post-Public Health Emergency with Mei Wa Kwong, Juris Doctorate and Executive Director at the Center for Connected Health Policy. Please reference your full bio on the attendee website. You can reference your screen for the continuing education, accreditation, and disclosure statement, as well as the continuing education tab on the attendee website. Please see the right of the screen for the learning objectives. And without further ado, your speaker.
Hello, thank you everyone for being here today. And thank you also for the Mountain State Regional Genetics Network for inviting me to speak to you about telehealth policy and what it looks like in a post-PHE environment. As was mentioned earlier, my name is Mei Kwong. I'm the Executive Director at the Center for Connected Health Policy. Before we get started, I always have to start off with a couple of disclaimers. Please know that any information that I provide today should not be considered legal advice. It is strictly for informational purposes. CCHP always recommends that you speak with legal counsel if you are interested in a formal legal opinion. And also know that CCHP has no financial interest, arrangement, or affiliation if I happen to mention a company or show a picture of their product. A few bit of information about CCHP. We were established actually as a California telehealth policy organization in 2009. We're a program underneath the Public Health Institute. We became the federally designated National Telehealth Policy Resource Center in 2012, and that's through funding from HRSA. We've been serving in that capacity ever since. So we've been in existence for over a decade as the National Telehealth Policy Resource Center. We work with a variety of funders and partners on the state and federal level on other types of connected health projects. And we also act as the national administrator for the National Consortium Telehealth Resource Center. What that is actually there are 14 telehealth resource centers underneath the same funding program that CCHP is. CCHP is the National Center on Policy. There's another National Center on Telehealth Technology and 12 regional resource centers that focus in on specific states. So I highly encourage, if you are interested in telehealth or have questions around telehealth, reach out to your regional telehealth resource center because they are there primarily to answer your questions regarding telehealth. And that's everything from what is it? How do I get started? What's the reimbursement policy for Medicaid around this item of telehealth? And when they run into questions that they can't answer on the policy level or on the technology level, they elevate them up to the national centers to try to help out as well. So a couple of years ago, the telehealth resource centers realized that there may be some work that we had overlap on with each other. So we decided to assign a portion of our federal funding to basically a common pot to fund these sort of more collaborative and common activities. And CCHP acts as the administrator of those funds and sort of the coordinator of those actions. And we also act as sort of a single point of contact. So people who are trying to reach out to multiple telehealth resource centers aren't quite sure which telehealth resource center they should be reaching out to, can contact the National Consortium and they can be directed. So we try to provide a little bit more of an efficient channel for folks to locate their telehealth resource center. CCHP, which is based in California, also is a convener for a group in California called the California Telehealth Policy Coalition as well too. So I've been asked to talk to you about telehealth, the telehealth landscape and telehealth policy in a post-PHE environment. So I'm just going to go through very quickly, probably what everybody knows is the timeline of like what happened with COVID. First declared in January of 2020, the federal public health emergency ended this year in May 2023. And actually quite a few states, depending on what their policies were, may have ended their public health emergency and their waivers around telehealth before that federal PHE actually ended. So, if you're talking about telehealth policy and where it is on a post-PHE landscape level, you have to keep in mind that you're talking about two different areas. There's one that is impacted by what happened on the federal level and what happened on the state level as well. And sometimes those policies align because a lot of states did tie their telehealth related waivers to when the federal public health emergency would end, but also quite a few states did not do that as well too. So just keep in mind that there are two sort of channels that you always have to consider when you're talking about telehealth policy, what they're doing on the state level and what they're doing on the federal level. And we'll go into a little bit more detail on that as I dive into some of the issues that we'll cover today. This is just sort of a high level overview of the telehealth changes, temporary changes that took place during COVID, both on the federal and state level. And you can see there are some areas where both the state and federal administrations like address the waiver, for example, such as location of where telehealth could take place, the type of services that would cover. And then there are other issues that were exclusively on the federal level to control or on the state level. For example, on the federal level, there was HIPAA and also prescribed and controlled substances. But when you look at the state level, something that was exclusively theirs to control was licensure. But this is like a very, very high level overview of like the telehealth policy changes that happened in response to COVID-19. Now, what was the impact on telegenetics? What happened was during the pandemic, really the telehealth policies opened up both on the state and the federal level, in that there was a relaxation on some of the barriers that were to telehealth, which quite frankly, before COVID-19, there were quite a few barriers as they applied to geneticists and how they could use telehealth. So when COVID-19 hit and they were relaxing some of these telehealth policies to allow for more expanded use, that was a benefit to a lot of providers and practitioners, not just geneticists. Keep in mind that telehealth policy development, there are sort of four channels that impact that development and impact how that policy is formed. You have laws and regulations, which probably most people are familiar with, but also keep in mind that administrating agencies also issue guidances, policies, letters perhaps, such as all provider letters that a Medicaid program might issue. CMS during this time has issued a lot of guidances that weren't laws or regulations, but were explanations of like how they would be implementing policies. So those are very very important to be familiar with. An additional sort of impact on telehealth policy are court cases. So that often gets overlooked by people working in the policy arena for telehealth. And that can actually have a significant impact on how telehealth policy is formed. So I would also, advise you to keep an eye on court cases. And sometimes the court case may not have anything to do with telehealth. There have been instances in the past where there's been a court case that has absolutely nothing to do with telehealth, like a completely unrelated subject, and it's had a significant impact on telehealth just because of the arguments that were made could be applied to a telehealth situation if you encountered a barrier. So these are like the four sort of channels that really impact development of telehealth policy. But for the most part, today we're just going to be talking about the first three levels. Now, I'm going to be covering three major issues today regarding telehealth policy. There's like a lot of policy that impacts telehealth. I'm not going to touch upon all of them. And even today for these, I'm going to be doing a very high level overview. We're not digging deep into this because that will take a lot of time to do that. And we don't have that today, but you can go to the CCHP website to gather more information. So the areas that we'll be covering are reimbursement and coverage, which actually makes up the majority of existing telehealth policies and laws and regulations, and then licensure and prescribing as well. So those are three major areas that I think probably have the most impact on how geneticists and really all providers, how they utilize telehealth to provide services to their patients. So those are the ones that I'll be covering today. The first one and the big one is reimbursement and coverage. And you have to keep in mind that reimbursement policy for telehealth, really there are four sort of main areas that the policy usually touches upon: service, location, provider, and modality. So for example, you may have a Medicaid policy that says this Medicaid program will cover behavioral health and mental health services if it's provided in the patient's home or in the doctor's office or a hospital or clinic. And if it's being done via live video and the provider is a psychiatrist or a licensed social worker. So you'll see if you look at telehealth reimbursement and coverage policies, they're usually touching upon one or more of these issues as they form them. And that's what a lot of the response during COVID-19 was actually applying to like one of these issues, the waivers. Now for telegeneticists, probably the most important two categories that impact you as far as your use of telehealth is probably the service and the provider, whether the service will be covered by the payer and whether the provider, the geneticist, is a provider that's eligible to use telehealth and have their services covered when they do that. So those are probably the biggest stumbling blocks at first for you guys. And then location modality obviously has some impact as well too, but these are like the first hurdles you would probably have to overcome in order to have your services, if you provide them via telehealth, reimbursed. Keep in mind also, as I mentioned earlier, federal and state policy developed separately and they can differ quite significantly in what they may cover. So again, you have to keep in mind it's a two-level sort of process that you have to keep in mind, or two levels of different types of policies. You could have it a federal policy, especially if your patients are Medicare, or you have state policy if your patients are Medicaid or maybe commercial payers. So as I mentioned, a lot of the established policies surrounds reimbursement and coverage, and then we'll also talk about prescribing. And prescribing, a lot of the policy really talks about how a patient-provider relationship is established. And then licensure, especially if you have patients that are located in different states from where you are, that's going to impact you as well too. Now, some of the temporary changes on the federal level have been made permanent, really for the most part, not really through legislation. They've been more actions that CMS have taken administratively, although there have been some federal actions legislatively that have impacted telehealth policy. For one thing, it was Congress that made the change to extend a lot of the temporary waivers for telehealth and Medicare until the end of 2024. They've also made some changes that would be permanent policy going forward after we're out of like this grace period, after all the waivers have expired, etc. So there has been some action on the federal level, but really a lot of the major pieces of telehealth temporary policies that we saw during COVID are still in that temporary phase. They have not been made permanent. And that's because Congress would need to act. That's not something that CMS can do on their own. What CMS has been able to do has been able to make some changes that we know will be permanent. Some have been around how federally qualified health centers and rural health clinics can provide mental health services now via telehealth. Some of their temporary changes they have made permanent, like very more sort of defined ones, such as, frequency of visits for certain types of facilities, etc. But for the most part, the major pieces of the telehealth waivers on the federal level and for the Medicare program, we're still waiting to see what Congress is going to do because they are embedded in federal law and we need to have Congress act on that. It's not something that CMS can do on their own. Reimbursement and coverage, the Medicare policy. I'm going to spend a little bit of time on this and you might wonder why I'm doing this. I'll explain in a moment. But with Medicare, they have two approaches to delivery of healthcare services via technology. They have one bucket of services that they call telehealth, and these are services that are essentially a one-to-one replacement for something that takes place in person. I go into my primary care provider's office for a regular visit, a consultation. That can be done also via telehealth. So that's a one-to-one replacement for something that can be done in person. There's also a set of services that can be done through technology that typically are not done in person or aren't even covered in person. For example, I have high blood pressure. I'm taking readings several times a day for a period of time, say a week, and I'm sending those to my practitioner. I'm not doing that in person. I'm not going into their office several times a day over a period of a couple of days and having my blood pressure reading taken. So those types of things that we can do now via technology, but there's not a one-to-one replacement for it. CMS call those communications technology-based services. Now, aside from that difference of a one-to-one replacement, what's the difference here in Medicare and how CMS views it? Well, those services that they call telehealth are underneath those restrictions in federal law for telehealth. So for those who are familiar with telehealth policy, it's those things such as, the patient needs to be in a certain type of geographic location. Only these certain providers can provide this under permanent telehealth policy. We're not talking about the waiver situation. But underneath permanent policy, all those restrictions would apply to those telehealth services. Communications technology-based services are not considered telehealth, so those statutory restrictions do not apply to communications technology-based services. CMS has other requirements on them, but there's not like a law or statutory limitation to these things. There are administrative limitations, and the importance of that is that CMS doesn't need to wait around for Congress to make changes in these communications technology-based services. I'm spending so much time over this is because during the pandemic, this got very confused, I think, for a lot of practitioners, particularly if they were new to telehealth. And, they were having questions of like, why am I getting so much less money? I just did an office consultation with my patient, and then you said telehealth would pay the same in Medicare, regardless if I did it in person or via telehealth for an office consultation. And I would ask, well, what did you bill? And they would give me a code that was actually communications technologies based code. And I said, that's on a different fee schedule. That's why you got less. So it got a very, very confused, I think, for some practitioners, particularly the newer ones to telehealth during the pandemic. So I just want to make that clear distinction for folks if they're not familiar with this. When you get down to the state level, it gets even more muddied. All that explained just before, that's Medicare policy. Some states have adopted these communications technology-based services codes as well. Some of them have included them underneath their telehealth policies. Others have them separated out like Medicare. So it's going to depend on what state you're looking at. And also some states don't reimburse for them as well. So again, it's a very confusing landscape, a lot of layers to it. So Medicare policy before 2020, if you're not familiar with it, I mentioned it earlier, very, very limited. It had limitations on where the services can take place, the type of provider can provide the services, the modality that was used, and the services that were covered. That got expanded a bit for COVID-19, especially like the provider category, particularly in the case for geneticists weren't necessarily listed as eligible providers in the Medicare program to provide these services. And also from my understanding, I think some of your services just aren't covered by Medicare as well. So that can be a bit of a hurdle for you too. Now, this is, again, a quick overview of what is still sticking around. As I said, some of the major items are sticking around, some of the major telehealth waiver items, such as the geographic location, the types of providers who can provide services, are sticking around temporarily until the end of 2024. And that's because of certain legislation passed by Congress. Others are expiring or have expired. On the next slide here, as you can see, a couple of things have expired, and those first couple lines there, the first two lines, those are actually CTBS services as well in the Medicare program. So certain parts of it or certain aspects of those have like expired already with the end of the PHE. Some of them are just gone completely, like the flexibilities to start law. And then some were already made permanent because they were things that CMS didn't have to wait for Congress around to make the decision to make permanent. They just went ahead and did them themselves. So the question is we're in this temporary phase. What's it going to look like in the future? And the question is, or the answer is, we're not quite sure yet, because some of those major things will require Congress to act, and we're not quite sure what Congress is going to do. It's a bit of wait and see at this point. I have this up as coverage and reimbursement in Medicaid, just to give you an overview of how drastically it's changed from 2019, which was pre-pandemic, to the first quarter of this year, basically, post-PHE almost. And as you can see, there's definitely been a shift in like the Medicaid programs on the state level as far as their telehealth policies. The biggest one I want to point out to is on the 2023 column, that second from the last bullet point. 36 state Medicaid programs reimbursed for some audio only. You will see that did not exist in 2019, simply because Medicaid programs did not consider audio only to be a part of telehealth. Significant shift in policy because of the pandemic. More than a majority of states are doing at least some audio only coverage in their Medicaid programs. Now, I will say there are usually a lot of restrictions, or it's very narrow. A lot of those audio only policies surround behavioral and mental health services, but it is a significant shift to now see this essentially a fourth modality, when if I were to do this talk pre-pandemic, I would be talking about 3 modalities, not 4 modalities now. Here's a sort of an example of how states can differ in their Medicaid policies, California and Alabama. As you can see, there's like significant differences in their approaches. California, for example, says all services that they cover in Medicaid programs that can deliver via technology, they'll cover it. Alabama has a very specific list of CPT codes or services that they say that they will cover, very similar to what CMS does. The modalities that are allowed, they both allow live video and audio only. They also allow remote patient monitoring, but California allows only a very small set of codes for remote patient monitoring. California also allows for store and forward. So as you can see, states can differ widely as well too in what they will cover for telehealth delivered services. Now I'm going to go into prescribing, and this is where I give you a warning of, I know you had access to my deck in another area, so you can download a copy of it. It's out of date because I submitted the deck a couple of weeks ago, and there have been some changes, particularly around here, around what prescribing controlled substances that had just literally happened a couple of days ago. So I have told our host that I will send an updated PowerPoint to them within a couple of days with the new information. So I just wanted to alert people who may have downloaded or looked at a copy of this presentation that was already posted, that it's a little bit inaccurate just because the information is not quite up to date because of recent actions that have taken place. So this is just a timeline of how telehealth policy developed on prescribing controlled substances. And again, prescribing of controlled substances is in the federal jurisdiction. Prescribing of everything else belongs to the states. And how the feds approached it is that they provide very limited scenarios in which telehealth can be used to prescribe a controlled substance if that telehealth provider has not had an in-person examination of the patient or fallen into one of the narrow exceptions where they allow telehealth to be used in lieu of that in-person examination. One of those exceptions is when a public health emergency is declared, and that's what happened with COVID-19. So Congress did not act to allow prescribing controlled substances during the pandemic. There was already an existing federal policy on that just got automatically activated when the public health emergency was declared. But that also meant once the public health emergency officially ended, it would automatically revert back to these very narrow exceptions here. So the DEA had to act with, putting out what they were going to do in a post-PHE environment. And earlier this year in March, they issued 2 notices of proposed rulemaking saying, well, this is what we were going to do. And it did not go over well. So their 2 proposed rules involved the induction of buprenorphine for a patient who was diagnosed with an opioid use disorder and prescribing of non-narcotic controlled substances. And basically what they did with these was to create just another narrow exception on how telehealth could be used. Plus they created deadlines of those who had formed patient-provider relationships without an in-person exam during the pandemic, a very sort of short timeline in which they needed to meet that qualification then, or they would not be able to prescribe in future time. So that was published in Federal Register on March 1st, 2023. There was a 30-day comment period and the people spoke. There were over 35,000 comments. Actually, it was closer to 38,000 comments that the DEA received, that people were just not happy with these comments. And for those who aren't familiar with this, the DEA actually has to read all 35,000 or 38,000 comments and write a response to them. They, of course, could do it collectively, but basically they have to read, process, etc., and respond to them. So in May, just a few days before the end of the public health emergency, DEA said, like, okay, you know what, we're going to temporarily allow the way it is now during the public health emergency, we're going to keep that around until November 11th of 2023. Then we're going to give an additional year for those who established those relationships from November 11th and before to continue to prescribe for an additional year. But during that year, you've got to make up that in-person visit. So we were in this another sort of like temporary holding period as far as the DEA was concerned in prescribing controlled substances. What's happened since then? the DEA held September listing sessions, and they came out with, they were indicating that they may have another comment period. And just a couple of days ago, they said, you know what, this temporary period, the way things were with prescribing of controlled substances during COVID, we're going to keep that around to December 31st, 2024. So in that time, there's probably going to be another comment period, or there may be more proposed rulemaking put it out so people can do more comments. But what we know now is that telehealth providers can continue to prescribe without that in-person exam or falling into one of those narrow exceptions until the end of 2024. So what we also know is that a lot of major things are coming to the head and will end by the end of 2024 unless further action is taken. Now, what are the states doing? As I said, states cover everything else regarding prescribing. That includes established patient-provider relationships, and practically every state allows live video to be used to establish that relationship. A few allowed an asynchronous or store and forward to be used as an option to establish that relationship, but that's rare, it's less common. Keep in mind, though, that the states can put or have limitations on prescribing of other things as well, too. So there are states with limitations on prescribing of abortion-inducing drugs, on prescribing of vision and hearing aids, such as glasses and contact lenses, and also prescribing of marijuana. So again, you have these different levels of policies, what the feds control, what the state control, and they may take different approaches to what they're doing as far as allowing telehealth to be used. The last thing I'm going to cover is licensure. Essentially, if you are providing services to a patient in another state, you must be licensed by that state. That's the rule for the most part. There are certain exceptions allowed. Most people are familiar with licensure compacts. These are agreements between states of how they would address the licensure issue. The physician one means that there is an expedited process that you can get a state license in another state if you are licensed by a compact member state and you are applying for a license in another compact member state. There are other compacts that basically are, you have one license in a compact member state, you can practice in other states, and that's what the nurse licensure compact is. So there's actually a variety of compacts that touch upon different professions. There's one for, I don't believe the social worker one is active yet. It might be, but there's one for PTs and OTs and other types of healthcare professionals as well. What we are seeing now in telehealth policy that we were not seeing before the pandemic are other avenues and exceptions that are being made. Florida, for example, has a registry, which if a provider gets on that registry, the physician gets on that registry, they're considered a good actor. They don't need to get a Florida license. There are exceptions states are making, such as if there was already a patient-provider relationship established and then a patient goes into their state, they're fine with that for a temporary period of time. Or if there are infrequent actions, such as, for example, you're providing services to a patient like 3 or 4 times a year. And they said, well, okay, well, then you don't need to get a license. So there are these exceptions that we're seeing more and more that did not exist before the pandemic, or maybe they did unofficially and they were just making it clear now in their policy. So what's our current status? We are, again, definitely on the federal level of Medicare in a bit of a holding pattern. A lot of the major exceptions or waivers will expire at the end of 2024. Some may expire a little bit sooner. Some are expiring here at the end of 2023, unless CMS takes some actions. And then we're not quite sure where they might end up, because they will require Congress to act. And, given where we are in Congress with other issues, I'm not quite sure what's going to happen with telehealth itself. What the states are doing, most states have already settled their policies, although there are a couple of states that have temporary extensions as well. Maryland and Connecticut, for example, have a future date of when they're ending their waived telehealth policies or their temporary telehealth policies. But what we'll probably see is sort of more further development of the things that I just covered, such as expanding Medicaid, or really also what we're also seeing a lot in Medicaid is a lot more study on that. and trying to gather data on that Medicaid programs in the past have not really focused on, but really looking at the data for telehealth usage and its impacts in the Medicaid programs. And then licensure and prescribing will continue to be, significant issues that will be covered. So that is it. That's my quick overview. If you want to delve deeper into it, you can always visit the CCHP website. We also have a newsletter that you can subscribe to. And this is our contact information. If you can't think of your question now and you want to do a follow-up, just go ahead and send it to us at that email address. And I am happy to take some questions now, and allow me to also stop my video, my share screen here too.
Great, thank you for that. That was a lot of information.
It is. I could have gone a lot deeper, but I'm not sure we have the time for that.
Well, we definitely have questions in the chat box here. So, so the first one is, are there any, so let me remind everybody, we do have a lot of questions, not sure we're going to get to them all, but if you do have a question, please put it in the question tab on the attendee website. Okay, so our first question is, are there any data around the economics of telehealth versus traditional face-to-face services? And do visits typically cost the same or less?
So there is actually quite a bit of data. It really kind of depends on really what specialty that you're looking at, or if you're looking at a specific condition. So there's various pieces of data that's out there. So if there was something specific that you had a question on, I'm happy to try to answer that. There's a lot of data in showing behavioral health services, because a lot of people are more comfortable with telehealth and in the behavioral health space. So the efficacy of providing that service via telehealth, there's a lot of good data around that. As far as the payment, it depends. So Medicare and Medicaid, if you are talking about telehealth, so keep in mind that CTBS, communications technology-based services area that I talked about, that's on a different fee schedule. But if you're talking about telehealth services, Medicare and Medicaid usually is parity in payment. They usually pay the same. Medicaid programs are required to do that unless they submit a state plan amendment to CMS. When you're talking about commercial payers, and I did not cover this, but there are commercial payer laws in the states on directing health plans or telling health plans how they're supposed to cover telehealth delivered services and how much they're supposed to reimburse. The majority of states have laws that at least say something about coverage, but not all of them have parity of payment in their state laws. So a state law could say, health plans, you are required to cover services regardless if they're delivered via in-person or telehealth, but there's no mention that they need to pay the same amount. So it's going to depend on what state you're in, and also how they crafted that language. I always say, well, if I could spot a loophole in there, I'm pretty sure a health plan could probably spot that same loophole. So it's got to be very clear in that as well too. And what's gotten also confusing, I'm not sure if folks have seen this, but I think there have been news articles recently about Aetna scaling back on their telehealth reimbursed services. And I took a very, very quick list at those lists of codes that they were talking about. Some of those codes were communications technology-based services code. So keep in mind, a lot of state laws say, well, if you cover it in person, you got to cover it via telehealth and pay for it the same. But if these are services that were technology-based, they can say, we didn't do those in person. These were all technology-based services. So that doesn't mean they're violating the law then.
Thank you. Very true. So why were there barriers for genetic providers to use telehealth versus those providers who did not have the same barriers prior to COVID-19 public health emergency?
The main barrier probably was because that there were a specific list of providers that were eligible to provide those services via telehealth. OTs and PTs faced the same things. There were a lot of Medicaid programs, and the Medicare program did not allow OTs and PTs to be eligible providers. Usually, if you're a doctor or nurse, you're fine, but genetic counselors were not probably listed as the eligible providers. So that was the main barrier existing. And it wasn't that you were singled out. A lot of healthcare practitioners faced that before COVID too.
Right, next question is, it seems there's still telemedicine stigma, less from patients, but more from other providers who seem to think that it is less valid form of care. Telemed genetic counseling as an example. Ideas on how to combat this?
I don't want to make a generalization that some of that might be generational in like sort of like that resistance to telehealth as well too. But to combat that, I think probably one of the best things is really like the patient acceptance of it, of like, you know, having patients. That was one thing that held back telehealth in general, I think, before COVID at all, was like patient awareness that it existed. I think having patients, you know, raise their voices or like make their voices heard, and that this is something we like that will benefit us. We would like to see more of it, will help, I think, maybe convince some of those providers on that issue. The other thing is that they may not be familiar with some of the studies that are out there on the efficacy of telehealth and, you know, how much it can do to, you know, assist with their patients, and also to help level the playing field, I think, or help, you know, provide greater access for patients who may be going without or going with infrequent, you know, visits, which they could benefit from, like, you know, more access to care.
Thanks. So who should genetic counselors liaise with within healthcare systems to explore the possibility of telehealth services?
Within healthcare systems, medical directors are really good. So you know, I've like seen some really great medical directors who are champions of telehealth, who really pushed it forward in their health system. So that would probably be a good start as well. More and more, especially with the pandemic, people have like created like a telehealth position in some way. So maybe getting engaged at least first with that person as sort of like, you know, who's the person that I really need to get to. They may be able to direct you to like the better person. It may not be the medical director, it may be somebody else. It may be like the CFO, to be quite honest, like, you know, the people in charge of finances who might be the ones who could help push it really through a lot further. So I would say, like, first off, if they don't have like a designated telehealth person, to maybe try the medical director.
Thanks. So when federal and state rules differ, which one should be followed?
So the rule of thumb is federal usually controls, unless if there's a conflict between state and federal policy, federal will control. So, but what I mean is by a conflict, like it's got to be almost a contradiction. Like, for example, you know, the federal law is that you must wear red on Sundays. And then the state law is like, no, you must wear blue on Sundays. There's a direct conflict there, then the federal law would control. But if the state law holds you to a higher standard and it's not in conflict with the federal law, then state law is fine. The state law is fine. So for example, HIPAA, I always say HIPAA is your floor. That is the minimum you need to meet as far as like protecting patient health information. But a lot of states have more stringent requirements. I mentioned I was in California. California has a higher level of requirement protecting patient health information. It's not in conflict with HIPAA, it's a higher standard. So the feds actually don't have a problem with it. So if it's in direct conflict, the feds control. If it's like a higher standard and it's not in conflict with the federal law, the feds don't care, and then the state law would control.
Thank you. And I have a clarifying question. When you said located, meaning the person needs to be located in the same state as the physician or the provider that's holding the telehealth appointment, do you mean live within that same state as the provider, or be physically at that point of the appointment in the same state?
Physically at that point of the appointment. So it's only when the telehealth interaction is taking place, the location of the patient really decides the majority of the policies taking place. That means, like, you know, the licensure issue for the practitioner. It may also be the reimbursement coverage, such as, like, you know, let's say that patient is a Medicaid Medicaid recipient, their coverage is Medicaid, and then the Medicaid program says like, oh, but they need to be in a doctor's office or a clinic, and then if the patient's at home, then that interaction won't be covered because that Medicaid program says no, they have to be in these certain locations. So for the most part, the patient location rules. There's some technical stuff, and I was just talking about this with somebody else like just a couple of days ago. There's some technical stuff with CMS about like, you know, the payment amount to the practitioner, where it's the practitioner's location is what kind of controls what exactly that payment amount is. And that's with CMS and Medicare. But for the most part, it's sort of like the patient location kind of rules on the policy. So like, you know, what where they're located during the interaction, and also like the physician's licensure issues as well. And also some of the prescribing stuff. I mentioned the state prescribing laws and abortion-inducing drugs. That's like that whole debate going on with reproductive health and like the prescribing of issues. It's because the patient location kind of controls that.
Okay, thank you. Can you give us an update or any background on the Medicaid, Medicare reimbursement for genetic counseling? Is there reimbursement for care coordination?
So on the Medicaid side, it will again depend on what state you're located in. We do track the telehealth policies for Medicaid programs. I'll be honest with you, I don't recall genetic counseling coming up a whole lot in the policies that we examine. The one caveat I would put to that is that some Medicaid programs write their policies very broadly, so it might be covered. Just because of how broadly they wrote their policies. But what that also means is they wrote it so broadly, it may not be covered as well too. We just simply don't know until you dig deeper into it. And then on the Medicare side, Medicare side would be more on, is the service itself covered? And Medicare, as I said, has a very specific list of services that they will reimburse if telehealth is used. It's like about right now during our temporary period, it's like about over 200 different CPT codes. Things related to genetic counseling, quite honestly, they're not jumping out at me. I'm not saying they're not on that list. And that list, and you know what, I'll slip it into the updated PowerPoint deck when I send it. The list is actually available online, like CMS like publishes that list, so you'll see it. And I will put that link. I don't have it in front of me right now, or I would put it in the chat, but I'll put it in the link in my updated PowerPoint when I send it to the host here.
Okay, thank you. And can you expand upon I think this will be our last question. Can you expand on what was relaxed regarding Stark law during the public health emergency?
Oh, so Stark laws sometimes, and this was actually even before the pandemic, Stark laws sometimes run afoul of certain arrangements people may have with like telehealth providers as far as like contracting of like, you know, services and like, you know, sending patients to them. It usually was not an issue for a telehealth program because there were so many safe harbors and exceptions that they can fall into. The waiver that they did with during the pandemic was essentially they said, we're just not going to ding you when you set up these telehealth programs, because they realized there were going to be so many people that were setting up telehealth programs and they knew they needed to do them quickly. So they didn't want them to wait until they consulted with their attorney to like, you know, map out how they were going to write their policies to make sure that they didn't run afoul of the Stark laws that, you know, go into the flexibilities, because people were just literally standing up telehealth programs overnight. So that was the only waiver. They were just saying like, we're just not going to go examine you during this period. We're just not going to like take a look at that. And now they said, now that we're in the post-PHE period, you do have to follow those Stark laws. But there are like so many exceptions and safe harbors that are there. It's not going to be an issue. You just need to like figure out which one fits best with your situation. They essentially said, we're turning a blind eye for these 3 years because we know practitioners and health systems were just like literally standing these up like overnight, and you didn't have time to go through all those details.
Great, thank you so much. I think that was helpful. I know a lot of it had to be more federally presented, but I still think it was helpful.
All right. Thank you so much for having me.
For more information, visit mountainstatesgenetics.org/contact. This activity was brought to you by Mountain States Regional Genetics Network. Please enter this code in the evaluation survey in order to claim Genetic Counseling CEU GS23-09.